I want to thank the organizers for inviting me to speak with you today about integrase inhibitors during pregnancy, and we'll discuss pharmacokinetic safety and efficacy, and I have no disclosures. So let's start with pharmacokinetics. This table shows PK data. Dolutegravir and raltegravir both have modest decreases in total drug exposure in late pregnancy. However, INSTI drugs are highly protein bound, and studies have shown no change in unbound active drug levels and no dose change in pregnancy is recommended. Elvitegravir is given with cobicistat boosting. There's a significant decrease in exposure in late pregnancy due to decreased COBI levels and pregnancy-related increase in CYP3A4 metabolism. Over half of women fail to reach target exposure above lower 10th percentile for adults, and more frequent viral load monitoring or consideration of regimen switch in pregnancy is recommended. There are no data on bictegravir in pregnancy and only limited data on CAB from clinical trials in the few women who became pregnant. They immediately stopped CAB, and the rate of CAB decline was similar to non-pregnant with drug levels still detectable up to 6 months postpartum. This table looks at placental passage in infant PK. Both dolutegravir and raltegravir have high transfer cord maternal blood ratios of 1.2 to 1.5, giving fetal levels 20 to 50% higher than the mother. Both have prolonged washout in newborns due to their immature UGT1A1 metabolism with a half-life of 27 to 33 hours. Dolutegravir transfers to breast milk with about 2 to 3% of maternal drug levels. Elvitegravir has cord maternal blood ratio of 0.9, giving infant levels similar to the maternal, and here infant half-life is similar to adults as the primary metabolism is CYP3A4. A recent paper using ex vivo placental perfusion model surprisingly found very low placental transfer for both bictegravir and cabotegravir. Moving to randomized clinical trials. There have been 2 efficacy trials of dolutegravir versus efavirenz started during pregnancy. The Dolphin-2 trial in South Africa and Uganda randomized 250 late-presenting ART-naive HIV-positive women at 28 to 36 weeks gestation to receive dolutegravir versus efavirenz. Median entry gestation was 31 weeks, and the endpoint was delivery viral load less than 50. The VESTED trial, conducted in 9 countries, randomized 643 ART-naive pregnant women, here at 14 to 28 weeks gestation, to dolutegravir TAF, dolutegravir TDF, or efavirenz, and here median entry gestation was earlier, 22 weeks, and the endpoint here was delivery viral load less than 200. Both studies showed superior viral efficacy at delivery with dolutegravir. In the Dolphin trial on the left, 74% of dolutegravir in green versus 43% of efavirenz in orange had viral load less than 50. 93% dolutegravir, 83% efavirenz less than 1,000. In the VESTED trial on the right, 98% of combined dolutegravir arms versus 91% of efavirenz had viral load less than 200, and the differences between the studies are related to different viral load endpoints and different antepartum ART duration. In addition to superior efficacy, both studies showed more rapid viral suppression, as shown in Kaplan-Meier graphs for less than 50 and less than 1,000 in the Dolphin trial. A meta-analysis of data from over 1,000 pregnant women from 5 trials was presented at the July IAS, 3 trials enrolling in late pregnancy and 2 in women becoming pregnant on study drug. Preterm delivery was higher with efavirenz than dolutegravir, no difference in SGA, no difference in neonatal death, stillbirth, or mother-to-child transmission. There were very few transmissions, but all were in the dolutegravir arm, and a non-significant trend to more stillbirth with dolutegravir. No difference in AE in mothers and infants, and no difference in adverse events between TAF and TDF. Thus, the short-term safety profile of dolutegravir and efavirenz were similar, and among the few pregnancies with preconception dolutegravir, there were no NTDs. The final trial is NICHDP 1081, conducted in 6 countries, randomized 394 ART-naive pregnant women to raltegravir in red versus efavirenz in blue at 20 to 36 weeks gestation. Endpoint here was again delivery viral load less than 200. Like dolutegravir, raltegravir had superior viral efficacy compared to efavirenz, with this difference driven by women entering at later gestational age and thus having shorter duration of ART prior to delivery. Raltegravir also had more rapid viral suppression than efavirenz. There was no significant difference in AEs, and mother-to-child transmission was 1% with raltegravir versus 3% with efavirenz, all occurring in late presenters. Now, as shown in these graphs, data from 2 randomized trials in non-pregnant adults, the ADVANCE and NAMSAL, found excessive weight gain with dolutegravir, higher in women than men, and higher with dolutegravir TAF in red than TDF in blue in the ADVANCE trial shown on the left. Now, given the known association of excess weight gain in pregnancy with adverse pregnancy outcomes, what do we know about dolutegravir weight gain in pregnancy and postpartum? So this graph shows weight gain data from the VESTED trial. Weekly maternal weight gain was significantly higher in the dolutegravir TAF arm in the dark green than the dolutegravir TDF arm in light green or efavirenz in orange. Now the blue box and line show the recommended weight gain in pregnancy. And you can see even with dolutegravir TAF, weekly weight gain is less than recommended for the general population. This slide looks at postpartum weight gain through 18 months in HIV-positive women on dolutegravir in blue or efavirenz in red and uninfected women in green in Botswana. HIV-positive women on dolutegravir had significantly higher weight gain of 5 kilos compared to efavirenz. However, compared to HIV-uninfected women, HIV-positive women on dolutegravir had similar postpartum weight gain. So in summary, dolutegravir or raltegravir started during pregnancy results in more rapid and superior viral suppression by delivery than efavirenz. Adverse pregnancy outcomes didn't differ from efavirenz, and while dolutegravir was associated with higher weight gain in pregnancy and postpartum, weight gain in pregnancy was actually less than recommended, and postpartum weight gain was similar to HIV-negative women. So I'll spend the remainder of my time providing an update on infant safety and neural tube birth defects. Just to remind you, the Botswana Tsepamo birth surveillance study was originally designed to evaluate the risk of neural tube defects with efavirenz exposure at conception. It's a prospective birth outcome surveillance for major surface birth defects, initially at 8 maternity wards covering 45% of Botswana births. Trained hospital-based midwives conduct a surface examination, photos are obtained if there's a defect, and a medical geneticist does a blinded review. And the study has a good denominator with control groups, including HIV-uninfected women, and able to distinguish type and timing of ART regimens in HIV-positive women. The study expanded to 18 sites, covering 72% of all births in Botswana in late 2018. Now, this figure shows you the initial results reported in May 2018. There were 4 neural tube defects among 426 dolutegravir exposures at conception for a prevalence of 0.94, compared to a prevalence of 0.12 with non-dolutegravir, 0.05 with efavirenz at conception, and 0.09 in uninfected women. And this gave a significant prevalence difference between the dolutegravir at conception and other exposure groups, ranging from 0.8 to 0.9. Data were updated in March 2019 when the number of dolutegravir exposures at conception had increased 4-fold. There were now 5 neural tube defects, giving a lower prevalence of 0.3. This compared to 0.1 with non-dolutegravir, 0.04 with efavirenz at conception, 0.08 for uninfected women. This was still a significant prevalence difference, now decreased to 0.2 to 0.27 between dolutegravir at conception and all other exposure groups. In April 2020, the number of exposures had more than doubled since March 2019, with 7 neural tube defects in 3591 dolutegravir exposures at conception, giving a lower prevalence of 0.19 compared with 0.11 with non-dolutegravir, 0.07 with efavirenz at conception, 0.07 for uninfected women. And this puts all of the graphs together, showing the evolution of NTD over time. And you can see for the non-dolutegravir groups, the prevalence has remained pretty much a straight line. For the dolutegravir at conception group in red, with increased number of exposures, the prevalence has significantly come down, but appears to have stabilized at about 0.19. Comparing dolutegravir to non-dolutegravir at conception in green, the prevalence difference is now 0.09 and is no longer statistically significant. The difference between dolutegravir and efavirenz at conception and HIV uninfected women remains significant at 0.12. Other pregnancy outcomes appear similar with dolutegravir and efavirenz regardless of timing. The graphs show any adverse outcome, severe adverse outcome, preterm, very preterm, SGA, very SGA, stillbirth, and neonatal deaths. And on the left, you see drugs started during pregnancy, and on the right, you see drugs started preconception. And I think you can pretty easily see that the data are similar regardless of timing and show no difference between dolutegravir and efavirenz. This slide looks at major structural malformations by type of exposure. NTDs accounted for 14% of these defects. And you can see in the red boxes that there were no significant difference in overall structural defects between dolutegravir and the comparison groups. And when you exclude NTDs, I think you can see pretty clearly the prevalence is similar in all exposures. I'll now review some of the newer data outside of the Tsepamo study. The Botswana Ministry of Health added 22 additional sites to the Tsepamo in Botswana, and together they covered 92% of all births. They evaluated over 3,000 births occurring over a 6-month period. One NTD was found in 152 dolutegravir exposures at conception, a prevalence of 0.66. There were no NTDs with other drugs in HIV positive women, and the prevalence was 0.09 in uninfected women. The prevalence difference was not significant given small numbers. And I just wanted to show you the Tsepamo data in comparison to the Ministry of Health. And you can see the upper end of the current 95% confidence interval for the Tsepamo study, 0.4%, overlaps that for dolutegravir conception in the Ministry of Health study. In Brazil, a case control study was conducted using registry linkage through national databases to estimate NTD risk with periconception dolutegravir versus non-dolutegravir treatment. No NTDs were observed with either drugs. There were higher abortions with periconception dolutegravir, but defects were not assessed in these cases. Of note, neural tube defect prevalence in Brazil with food folate fortification is 0.06%. And so a 3-fold increase to 0.18% is likely not to be detectable with only 384 exposures. And after the database closure for the case control study, 2 NTDs were identified with dolutegravir exposure at conception in an estimated 1,000 births, giving a prevalence of about 0.18. This shows you data from the Prospective Antiretroviral Pregnancy Registry just updated through July 2020. There are 1,127 periconception exposures to the different INSTI drugs, 420 dolutegravir, 331 elbiteragravir, 350 raltegravir, 51 bictegravir. The overall rate of birth defects is not significantly different between periconception and 2nd and 3rd trimester exposures. And there's been one NTD reported in the prospective data with periconception dolutegravir, giving a prevalence of 0.24%. Now, this slide shows you a review of all of the data on NTD with dolutegravir exposure at conception. I separated countries without from those with food folate fortification, which reduces NTD risk in the general population by about 40 to 60%. In reports from countries without food folate fortification, there are 8 NTDs out of 4,224 dolutegravir exposures at conception, giving a prevalence of 0.19%. And of course, this is led by the Tsepamo numbers. This compares with a general population prevalence of 0.1. In reports from countries with food folate fortification, there are 3 NTDs in 1,655 exposures to dolutegravir at conception, giving a similar prevalence of 0.18 compared to a general population prevalence of 0.06. So what about the other INSTI drugs? These are data just published in October from the French perinatal cohort, a prospective study of HIV-positive women delivering at 90 centers in France. They evaluated birth defects among 808 INSTI exposed mother-infant pairs, 301 exposed at conception. Raltegravir was the most common drug. Outcomes were compared with a matched HIV-positive group receiving darunavir-ritonavir, and you can see the rate of birth defects, stillbirth, preterm deliveries were similar, and no NTDs reported. This slide shows you data on reports of the other INSTIs. For raltegravir, Merck has published a review of their databases, including clinical trials, the APR, the French perinatal cohort, 456 exposures at conception. There have been 2 papers since then with an additional 55, no NTDs reported. For elvitegravir, Gilead reported a review of their database of 155 exposures at conception. 1 new paper with an additional 82, no NTDs reported. Finally, a small number of bictegravir exposures at conception with no NTDs. Now, Andrew Phillips updated his risk-benefit analysis of dolutegravir versus efavirenz to include the new NTD risk with the Tsepamo study and the effects of dolutegravir on weight gain and its potential effect on pregnancy outcomes. And in a range of scenarios in sub-Saharan Africa, a policy of starting treatment with dolutegravir, including in pregnant women and those intending pregnancy, was predicted to bring the most population health benefits and to be cost-effective. So in summary, dolutegravir and raltegravir are both highly effective drugs, especially in late-presenting pregnant women, and safe for the mother in pregnancy. Adverse outcomes outside of NTDs do not appear to be increased with use at conception. And after a period of decline since the original safety signal, the NTD prevalence among infants of mothers on dolutegravir at conception has stabilized at a low prevalence level of 0.19%, and it's no longer statistically significantly higher than non-dolutegravir at conception, although it's still higher than efavirenz in uninfected women. In a review of the literature, the prevalence of NTD in countries with and without food folate fortification is similar, 0.18 to 0.19. There have been no NTDs reported in prospective studies of other INSTI drugs at conception, but the numbers remain small. An NTD risk, if it remains with continued follow-up, appears to be significantly under 1%, with a potentially in excess of 1 NTD per 1,000 infants exposed to dolutegravir at conception, compared to the general prevalence of NTD in the overall population. And with risk-benefit analyses showing substantial dolutegravir benefit in women of childbearing potential, WHO now recommends dolutegravir as preferred for all individuals, including pregnant women.